didn't find any question in. Now we are going to proceed with Dr. Mohamed Mahmoud, next lecture.
Thank you.
The next lecture with Dr. Mohamed Mahmoud, Assistant Professor of Anesthesia in Cairo University, about anesthetic consideration in spinal surgery. Go on, Mohamed.
General consideration for spine surgery. We can do spine surgery when there is neurological dysfunction, or structural instability, or pathological lesions and deformity. Spinal conditions that require spinal surgery, specific to the spine, disc spondylolisthesis or spinal canal stenosis, some sort of deformities like scoliosis, kyphosis, or spinal tumors, or there is special spinal procedure like laminectomy.
عم في مشكلة في الصوت عندك.
سامعني كده؟
في خلفية عندك صوت عالي، ممكن يعني تقعد في حتة مقفولة شوية، إنه في خلفية عندك صوت جامد. proceed.
كده سامعني؟ طب كويس؟ كده سامعني؟
سامعك بتعلي صوتك شوية.
اوكي حاضر.
هو كل الكومنت قال ان في ايكو والصوت مش كلير، كلها الكومنتس جايه.
كده كويس، بس انا قاعد في اللوبي فعشان كده عشان الواي فاي بس.
اوكي، طب يعني اقفل الشبابيك اللي وراك او الباب عشان الاصوات بس.
This is diagrams for spinal conditions that require surgery. Cervical canal stenosis, collapse vertebrae, or scoliosis. This is conditions with normal disc, degenerative disc, bulging disc, herniated disc, and some deformities like spondylolisthesis. Anesthetic consideration. Preoperative assessment. First, airway assessment. We should consider temporomandibular joint, mouth opening, if there is any previous difficulty in intubation, or restriction of neck movement due to disease, or stability of the cervical spine. It is essential to discuss the cervical spine mobility with the surgeon before intubation. We should consider the respiratory system also, any existing ventilatory embarrassment before surgery, any signs of pulmonary infection, pneumonia, or asthma, any spine deformities like scoliosis or kyphosis. According to the cardiovascular system, besides routine examination, blood pressure, heart rate, sounds, we should take history around hypertension, diabetes mellitus, congestive heart failure, or coronary artery disease. We should do neurological assessment before surgery.
محمد الكل بيشتكي بالصوت. انت في عندك نويز جامده جدا وراك. في اطفال وراك.
طب لحظه عايز. معلش بعد اذنك. معلش بس انا في محاضره بس ممكن بس اطفال الصغيره صوت عالي قوي مش عارف. معلش بس. طب لو ايه ده تفتحها لي؟ ممكن اهولد دقيقتين بالظبط كده او اتنين لمكان تاني.
اتفضل. We are sorry for interruption. Tell Dr. Mohamed change the site of his lecture. Some logistic problems على رأي أصدقائنا الأمريكان.
Sorry. مش انا اسف خير. الواي فاي شغاله هنا؟ في فيشه؟ اقرب فيشه بس. السلام عليكم. كويس كده؟ الصوت كويس؟
هايل. ممكن
تمام.
معلش تبتدي من اول وجديد؟
حاضر.
باشمهندس احمد ممكن نرجع من الاول؟ اكسلنت.
Okay. General indication for spine surgery: neurological dysfunction like compression or structural instability, any pathological lesions and deformity and pain. Spinal conditions that require spinal surgery specific to the spine, like intervertebral disc lesions or spondylitis or spinal stenosis. Some deformities like scoliosis or kyphosis or spinal tumor, or some special surgical procedure like laminectomy, discectomy, or fixation. The voice is fine.
الصوت هايل يا محمد، كويس قوي.
Okay. This is diagrams for spinal conditions that require surgery. Spinal cervical canal stenosis, spinal tumors, kyphosis. This is pictures for disc herniation. Sorry, bulging of the disc herniation, movement of the vertebrae over vertebrae. And this is spinal. This is spondylitis. Anesthetic consideration: we should do some sort of assessment preoperative before spinal surgery, specific to some systems. We will start with airway system. Temporomandibular joint is very important. Mouth opening, previous difficulty in intubation, any restriction of neck movement should be considered. Stability of the cervical spine also should be considered. It is essential to discuss the stability of the cervical spine before surgery with the surgeon in order to make scenario for the intubation. We should go to the respiratory system. If there is any ventilatory embarrassment before, like pneumonia or asthma, any spine deformities like scoliosis or kyphosis. Cardiovascular system: routine examination, blood pressure, heart rate, routine history, if there is any history of hypertension, diabetes, congestive heart failure, or myocardial infarction before. Neurological assessment is very important for the anesthetist before spine surgery. The full neurological assessment should be documented. In patient undergoing cervical spine surgery, the anesthesia consultant or the anesthetist have the responsibility to do examination for the patient before intubation. Also, if there is any muscular dystrophies like Duchenne, Guillain-Barré, whatever the muscle disease, may affect bulbar symptoms and increasing the risk of aspiration. The level of injury and time elapsed since the insult are predictive of physiological derangement of the cardiovascular and the respiratory system, which occurs if there is before 3 weeks before injury. Spinal shock may be a landmark, and after this time we should take care from the autonomic hyperreflexia. انا عندي بس حاجه على مش عندي حاجه على الشاشه كده طالعه مش اوكي. Suggested preoperative investigations before spine surgery. According to the airway, we should do X-ray to the cervical spine review and inflection extension. We can do also CT chest. To pulmonary, we can do chest X-ray and pulmonary function test to blood gas spirometry. Beside the normal blood test like liver and kidney, CBC, coagulation profile. We can move to the anesthetic technique. Consideration of the severe pain of patient with degenerative disease. Opioids and as a pre-medication should be of limited use because there is some sort of difficult airway or ventilatory embarrassment for the patient. We should take care from the opioids. I can recommend a small dose from very minimal dose if there is need to sedation. Induction. Choice of the induction techniques: IV or inhalation anesthesia, according to the patient medical condition and the airway and the cervical spine stability. choice of the muscle relaxant, rapid sequence with succinate being or non-depolarizing muscle relaxant according to the timing of the injury or and the patient medical condition and if there is any risk of aspiration. احنا عندنا دياجرام هنوريه دلوقتي الجوريزم للانتيوبيشن على حسب السيرفايكال سباين ستابيليتي. انتيوبيشن هنتكلم عن الانتيوبيشن في السيرفايكال سباين سبيسيفيك. maintenance of anesthesia. We can maintain a stable anesthetic depth with good with inhalation anesthesia and maintaining normal blood pressure. In position of the patient, check airways, avoid sudden change in anesthetic depth or blood pressure, maintain constant depth of neuromuscular blocking, inhalation anesthesia or continuous infusion with propofol, controlled hypotensive anesthesia. الحقيقه يعني احنا مع النيوروسيرجي بصراحه هم ما بيحبوش قوي الهايبوتنسيف انستيزيا لان هم بيخافوا على السباينال كورد بالفيوجن. العظم هم كتير بيطلبوا الهايبوتنسيف انستيزيا بس احنا في النيو معظمهم يعني ما بيحبوش الهايبوتنسيف انستيزيا. بس احنا ممكن يعني نحافظ على المين بلاد بريشر within 25% من البيز لاين. ده هيبقى كافي جدا ان العيان هيبقى ما فيش البليدنج مش هيبقى كتير وفي نفس الوقت محافظين على السباينال كورد بالفيوجن. Reversal of the patient with oxygen and atropine 100% oxygen. Extubation should be done in free awake condition. عشان بتكلم بسرعه شويه عشان السلايدز كتير فمش يعني مش عايز اضيع وقتكم بقى يعني في حاجات مهمه بس هبقى مركز عليها قوي.
Mohamed, please your comments in English because we have an attendance from does not speak Arabic.
Okay. Prone position. Prone position is very important in spine surgery and in intubation in supine position. And then we turn the patient. We should need 4 people to turn the patient from supine to prone position. Head should be in neutral position. Neck should not be extremely flexed or extended. We should take care from the eye loop if there is any pressure on the eye. The arms should be beside the patient or in 90 degree. Should take care from in position of the elbow, position of the rib, of the wrist. Take care from radial and ulnar nerve position. Arms should not be extremely abducted because of the brachial plexus. In females, take care from breast, males external genitalia. All pressure sites should be examined or examined before start of the surgery in order not to make injury at the end of surgery. Anesthetic problems with in prone position, airway, intracal tube clinking, edema of the upper airways. In blood vessels, there is some sort of occlusion in blood vessels of the extremities or kinking of the femoral vein. Marked abdominal pressure may lead to increase of pressure in the abdominal in the epidural veins and increasing bleeding. This is a diagram for proper position in prone position. Take care from the anesthesia circuit. Sometimes disconnection can occur there. So extreme fixing of the anesthesia circuit is very important in prone position. Nerve brachial plexus, as I said before, peroneal nerve compression, lateral femoral cutaneous nerve compression, head and neck not extremely flexion extension, external pressure of the eyes, as I said before. There is a lecture around about position, complication of position, so I will not give more details about this complication. Spine surgery monitoring. There is routine monitoring, standard monitoring, ECG, capnography, invasive blood pressure, ECG blood, and there is some specific neurophysiological monitoring like wake-up test, somatosensory or motor evoked detection. Wake-up test, it's lightening anesthesia at an appropriate time during procedure and observing the patient's ability to move and obey commands. Evaluate the gross function integrity of the motor pathway. Wake-up test anesthetic techniques. It's maybe volatile-based anesthesia, midazolam-based anesthesia, or propofol, or remifentanine-based anesthesia. in my small experience, it is the most important thing is to tell the patient there is a wake-up test intraoperative. You will attend with your patient. You should tell him there is a wake-up test, and the details should be discussed with the patient. These advantages require patient cooperation, and there is some sort of patient foreign from the team. Somatosensory evoked potential, the most common neurophysiological method monitoring interoperative to monitor the spinal function integrity. The stimulus applied to the peripheral nerve, tibial or ulnar. The recording electrodes placed on the cervical region, scalp or epidural space during surgery. Baseline data should be obtained before skin incision, and the responses are recorded intermittently during surgery. A reduction in the amplitude by 50% or increase in the latency by 10% are considered significant. Somatosensory evoked potential tests only test the dorsal column function, not the motor function. Rarely post-operative neurological deficit reported in spite of preservation of the somatosensory evoked potential intraoperative. Anesthesia and somatosensory. Satisfactory monitoring of the early cortical somatosensory evoked potential possible with 0.5 to 1 mg isoflurane, desflurane, or sevoflurane. Nitrous oxide potentiate the depressing effect of volatile anesthesia. Intraoperative anesthesia generally affect the somatosensory less than inhaled anesthesia. Etomidate and ketamine increase the amplitude. Clinically unimportant changes in the somatosensory in latency and amplitude after administration of opioids. Etomidate, propofol, or opioids is preferable better than nitrous oxide or increasing volatile depths of anesthesia. Somatosensory, the most common motor evoked potential. Inhalation anesthesia suppress the myogenic motor evoked potential in a dose-dependent manner. Fentanyl, etomidate, and ketamine also have relative effect on motor evoked potential and compatible with intraoperative recording. Benzodiazepines, barbiturate, propofol market depression of the myogenic motor evoked potential. However, successful recording have been obtained during propofol anesthesia by controlling propofol concentrations and increasing stimuli rates. In some sort of neurosurgical procedure like fossa or CPA, we can use these techniques with neurophysiological monitoring to monitor somatosensory and the motor evoked potential together. We maintain the patient on TIVA with the Prevan and Brezdex. This is the available drugs in Egypt. Remifentanil is available, so we can use with remifentanil and make monitoring of the depths of anesthesia by entropy or by spectral. So this gives good result. Hypotensive anesthesia, lowering of the arterial blood pressure. It minimizes the surgical wound visualization. First, proper position and post-pressure ventilation, and administer and adjust the ventilator parameters as the professor said. Administration of intensive drug side or beta blockade TIVA inhalation anesthesia. Safe level of hypotension. In healthy young individual, mean arterial blood pressure as low as 50 mm/mercury is tolerated with chronically the patient with hypertension, chronic hypertension, we can tolerate up to 25% from the baseline of the mean heart rate, of the mean blood pressure. The relative contraindication to hypotensive anesthesia. Any patient predisposing with any patient predisposing illness that less on the margin of the safety for adequate organ perfusion, like anemia or hypovolemia, or renal or hepatic insufficiency. Post-operative visual loss is a rare but devastating complication. 1 every 1,100 after bone spinal surgery have post-operative blindness, whose may be optic neuropathy, 81%, or central artery occlusion, and 13%, 6% unknown causes. Pain management after spinal surgery, narcotic and analgesics, IV or intramuscular PCE, non-steroidal anti-inflammatory, paracetamol, ketamine, neuroaxial technique with alpha-2 blockers like clonidine or dexmedetomidine, transcutaneous electrical nervous stimulation and extended release formulation, epidural morphine. If there is any time or a time finished?
Listen, we have time.
Okay. I'll make focus on cervical spine surgery, especially cervical injury. Most common surgery with the trauma. Most common site is C5, C6 injury. The upper two cervical vertebrae differ from the last cervical vertebrae in anatomy. I will not detail differences with time. Primary injury, it occurs at the time of traumatic insult from the direct injury, joint dislocation or intervertebral facet joint or intervertebral disc or ligamentous tears. Second injury begins within minutes following the initial injury and can evolve more over several hours. Mechanisms include ischemia, hypoxemia, inflammation, lipid peroxidation, and cell apoptosis of neurons. This underlying pathological process results in further cord edema and it reaches its maximum within 4 to 6 days after injury. Many interventions have been tried to reduce the severity of the secondary injury, mainly experimental, but steroids, free radical scavengers, barbiturates, hypothermia, hyperbaric oxygen, and opioid antagonist. This is diagram showing the mechanism of injury. After injury, there is glutamate release and calcium influx, leading to lipid peroxidation and cell apoptosis and demyelination of the neurons. Measures aimed at ensuring adequate oxygenation and perfusion of the injured spinal cord and avoidance of hyperglycemia and hyperthermia are the mainstay of prevention, the main factor for preventing the secondary injury. Also maintaining spinal cord perfusion pressure. Spinal cord perfusion pressure equal mean arterial blood pressure minus spinal cord CSF pressure. Blood pressure should be over 90 millimeter mercury for 7 days after injury. Spinal injury is differentiated by lesions into 5 categories. Category A, which is complete, there is no motor or sensory, there is complete motor and sensory loss. Class B, incomplete, lateral sensory sparing. Class C, incomplete with motor sparing more than 3 groove muscles. Group D, incomplete with motor sparing for more than 3 groove muscles. Group E with normal motor and sensory. Spine protection, preferred spine protection with manual inline stabilization or neck cooler. Neck cooler not shows no complete protection, complicate the airway during the CPR, increase the ICP extremely if it is tight, interfering with the intubation sometimes. This is manual inline stabilization. This is diagram showing the intubation in cervical spine injury. If the cervical spine is stable, direct laryngoscopy, there is 2 directions. If the direct laryngoscopy is expected to be easy, and there is no risk of aspiration, so IV induction, normal with non-depolarizing muscle relaxant with direct laryngoscopy. But if there is risk of aspiration, so rapid sequence induction with succinylcholine before 3 days of injury, or more than 3 days, we can shift to another rapid sequence drug like rucoronium with direct laryngoscopy. But if the cervical spine still just expected to be difficult, and there is no risk, consider a sleep fiber optic or intubating laryngeal mask. And if there is risk of aspiration, so awake fiber optic from the start. The second line, if the spine is unstable, and direct angioscopy is expected to be impossible without neck manipulation through awake fiber optic from the start. But if the direct angioscopy may be possible, we can consider direct angioscopy with manual line stabilization or a sleep fiber optic or intubating angiomasp. Clinical picture of cervical injury, motor and autonomic dysfunction occur. The latter can lead to neurogenic shock or paralytic case. Emission management is ABC, airway, breathing, and circulation. There's two types of shock we should differentiate between spinal shock and neurogenic shock. Spinal shock, which is the immediate flaccidity, paralysis, areflexia, and loss of sensation below the level of the lesion. There is neurogenic shock, is distinct from the sympathetic fiber disruption that causes vasodilatation and hypotension. It occurs with high thoracic cervical spine and profound brain injuries above the level of T6. The triad of hypotension with bradycardia and hypothermia is characteristic for the neurogenic shock. Areflexia, loss of sensation, and flaccid paralysis below the level of the lesion. No epinephrine is able to maintain mean arterial blood pressure with lower intrathecal pressure and correspondingly higher spinal cord perfusion pressure. But also, if there is bradycardia, it is preferred to do epinephrine. Indication for surgery if there is indication for stability or restoration of the cervical spine, or exploration and decompression and destabilization of the neurological deficit and the neurological deficit is worsening, or exploration of open penetrating wound. Timing of surgery. There is no defined standard existing proof for the time of surgery of the decompression and destabilization of spinal cord injury. The role of immediate surgery intervention is limited. Emergency decompression of the spinal cord is suggested in the setting of acute spinal cord injury with progressive only neurological deficit. Facuro et al. Reported no significant difference between early, before 3 days, or late phase of intervention. In acute stage therapy, the first is to optimize critical care management and moderate the secondary injury cascade, which includes steroids, erythropoietin, minocycline, and LP2. This is a theoretical drug, most probably labs, inside labs. Role of steroids in therapy in cervical trauma. The second national acute spinal cord injury study recommended the use of steroids, and the third study trial, additional benefit was confirmed by prolonging the administration of steroids up to 48 hours in patients presenting from 3 to 8 hours. But if there is a revised recommendation from the Congress of Neurosurgical Surgeons and the American College of Surgeons has modified advanced methylprednisolone is a recommended treatment note rather than the recommended. The Canadian Association of Emergency Physicians is no longer recommended high-dose methylprednisolone as a standard of care. Updated guidelines in 2013 by the CNS and the American Association of Neurological Surgeons recommended again the use of steroids early after an acute spinal cord injury. Guidelines recommended that methylprednisolone should not be used for the treatment of acute spinal cord injury within the first 24 to 48 hours following injury. The previous standard was revised because of lack of medical evidence supporting the benefit of steroids in clinical settings and evidence that high-dose steroids are associated with harmful adverse effects. In chronic stage therapy, rehabilitation, and medications like epidermal growth factors, fibroblast growth factor 2, cyclic AMP, or activated macrophages, and stem cell therapy. Stem cell therapy, ongoing studies of adult mesenchymal cell therapy. Animal studies are promising, but human trial. Anesthetic considerations like any spine surgery and specific consideration to the airway, patient medical history and physical examination, airway management, positioning, intraoperative monitoring, somatosensory and motor evolved intention, fluid management exchange, and post-operative complications. The usual precautions are taken if the patient has a potential full stomach, but succinylcholine should be avoided if the patient is more than 3 days post-injection. Atropine or glycopyrrolate should be available to treat any bradycardia. Large oral access nasogastric tube should be placed as high acute cord injuries to gastric stasis and gastrointestinal illness. Spinal injury patient at particular risk of venous thromboembolism, compression stocking should be worn, and the calf compression devices should be used intraoperatively. Monitoring, as we said before. Fluid management, balance between maintaining volume to ensure adequate blood pressure for perfusion of vital organs, including the spinal cord, and avoiding the venous congestion that may lead to fluid overload. Cannulars and colloids can be used, but extrudes containing fluids are to be avoided because of risk of worsening the neurological outcome in the presence of hyperglycemia during spinal cord ischemia. Extubation should be done fully awake in the operating room immediately following surgical procedure. Post-operative ventilation may be required, especially if there is pre-operative pulmonary dysfunction or high cervical cord lesion or hemodynamic instability or prolonged procedure with massive blood loss and fluid shifting. Anesthetic management of chronic cervical spine injury should take care from the autonomic hyperreflexia or if the afferent impulses originating from bowel, bladder, manipulations of the urinary tract, childbirth, or surgical stimulation to massive sympathetic response from the adrenal medulla and the sympathetic nervous system, leading to severe hypertension below the level of the region and the multivascularization above the level of the region. This may lead to severe hypertension, pulmonary edema, myocardial infarction, cerebral hemorrhage. Noradrenaline has a major role because of extreme catecholamine release from the adrenal medulla. Deep general anesthesia and spinal or epidural anesthesia seems to be effective in preventing of the occurrence of autonomic hyperreflexia. DVT prophylaxis, hematological changes like anemia, denervation hypersensitivity, as we said before, temperature control in cervical spine patient is very important, infection, pneumonia, and UTI. Thank you.
Thank you, Mohamed.
Sorry for the long session, but I focus on cervical, focus on spine surgery per se, and make focus on cervical spine as a specific condition because it's very common to see cervical spine patient with all complications of cervical spine surgery.
Thank you, Mohamed, for this presentation. I would like to ask you about the safety of using laryngeal mask versus in manualized stabilization versus fiber optic intubation in cervical spine injury.
Believe me, still, I think intracal tube is the safest.
No, I don't speak about safety. If the patient, do you hear me? Mohamed, do you hear me?
Yes, yes, sir.
I don't speak about safety. Sometimes, if the patient is fasting, no fear from aspiration or vomiting, would you like to use laryngeal mask or in manual line stabilization with rigid laryngoscopy or fiber optic?
Fiber optic, if it is available, fiber optic #1.
Next,
fiber optic rigid laryngoscopy with manual line stabilization.
Okay, what's the problem with laryngeal mask?
First, it's head and neck surgery. Any manipulation with the surgeon over the pharynx, which is common, may displace the laryngeal mask during surgery. You asked about laryngeal mask all over the procedure. Yes, sir.
No. I ask about a station in the emergency room.
In the emergency room, #1, the fiber optic is available. I will proceed with fiber optic. #2, rigid laryngoscope and if the cervical spine is stable, but the cervical spine is not stable and there is no fiber optic, I will put intubate an laser mask and then put intratracheal tube to make intubation.
Okay, thank you. There was a question about would you prefer to use norepinephrine versus epinephrine in spinal or neurogenic shock?
According to the clinical picture of the patient, if there is hypotension only, we use norepinephrine. But if there is hypotension and bradycardia, epinephrine is more.
The sound is not clear, please. Mohamed, again.
If there is hypotension, if there is hypotension only, norepinephrine will fit. But if there is hypotension with bradycardia, I think epinephrine, we use epinephrine for a time in bradycardia and give a good.
Another question, what's about the use of laryngeal mask in prone position?
No, I cannot recommend. I know I know you said you can extreme at all prone position, abnormal position with laryngeal mask. In my small experience, I use laryngeal mask in supine position. Lateral position shoots ventilation with intratracheal tube. This is my own opinion. I cannot use laryngeal mask in abnormal position.
The question about two types of surgery, spinal surgery or general surgery.
قولا واحدا. Supine position, laryngeal mask equals supine position. In my opinion.
Okay, you are too conservative, guys.
Yes.
But the literature does not agree with you.
I know that there is a. Yes, I know the literature, but in each, according to the area, we can notice there is a marked change in head position. So yeah, it's more safe to use intratracheal tube to secure the ventilation.
Another question, ventilation in lateral position. The question is not clear. I would like to about.
As provided it is double lung ventilation, so it's like ventilation in supine or prone position. We adjust according to the entire C2 from 30 to 35 millimeter mercury in capnogram, and this is fine. As provided it is double lung ventilation.
Again, Mohamed?
As provided it is double lung ventilation, not lung ventilation, so it is normal ventilation to keep the entire CO2 from 30 to 35 on capnogram. This is fine.
So the sound is not clear. Another question. If the patient has a bulbar affection preoperatively, can we extubate him deep?
No, we should extubate awake to observe if there is a good cuff reflex of the patient, and we should extubate extremely fully awake to observe the movement of the vocal cord after extubation, and we should assess the movement of the vocal cord before intubation, before surgery with the surgeon, to identify if there is any risk of aspiration after extubation. If there is high risk of aspiration, so can go to tracheostomy at the same session.
Okay.